Purple Solutions to Fix Healthcare in America podcast. Each week, we explore bipartisan solutions to healthcare reform through discussions with leading experts from across the country. To learn more, go to purplesolutions.org and join us at our Healthcare Economics Summit on July 31st.
All right. Hello, everybody. I'm Dan Sam, Dean of the Batterman School of Business at Concordia University and Director of the ARCS think tank, here again with another issue of our Purple Solutions podcast. And I'm real excited again to have today Dr. Greg Watchmaker. And Dr. Watchmaker is a practicing hand surgeon here in Wisconsin. And his outcomes research in carpal tunnel syndrome have received top editorial honors by the journal Hand this year in 2020 for the most impactful published work in the field of hand surgery. And even though he's a practicing hand surgeon, Dr. Watchmaker started his education in the field of computer science and led a team at Washington University Medicine that developed the first medical software to map atrial fibrillation during heart surgery. So he kind of crosses medicine and informatics, computer science, and especially relevant for our discussion today. He's developed applications used to deliver hospital quality to the federal government, and more recently, patient-facing web-based outcomes assessment tools. Importantly for me is he is a contributor to our Purple Solutions book on the topic of unintended consequences of federally mandated quality reporting. And this is something we will talk about on the July 31st summit as well. So Greg, thanks a lot for speaking with me today and contributing to the Purple Solutions book. So before we get into the benefits or dangers of federally mandated quality reporting, which you'll tell us what that means, right now I hope actually, can you tell us a little bit about how the government monitors quality in the delivery of healthcare by frontline providers like you? How do they do this? What's the process?
Sure. Well, Dan, thanks for the introduction. Historically, when I first started in practice, the way the federal government collected most of their information is the care we provide turns into claims, which we then send to the federal government. And that claim information not only is used to process payments, but you can also glean a bit of information from that regarding what diagnoses a patient had and what treatment was rendered. So the earliest efforts were really done what I think of as in the flow of patient care. It was information that was moving out of our office anyway, and there was really very little burden to it.
Okay.
There are limits, though, to that information. And what happens is when the federal government wants to define more narrowly a specific target, they'll add on top of that information additional reporting pieces of information that they wish collected. And that now falls out of the flow, and there need to be processes then and web-based portals that the federal government creates, and then software on the hospital side, which is what you alluded to, iWrite, and also at the private practice and group practice level, there needs to be additional personnel and software that inputs this information in order to send it off to the federal government. So we've really, over the last 20 years, as quality measures have become more complicated, we've kind of pivoted from information that occurred in the flow of patient care to information that is collected that is outside that normal flow of information.
Is this mostly through like Medicare and Medicaid, or is it broader than that?
Medicare, just because the federal regulations are what we are typically responding to, they are the ones that are very complex and have a lot of data fields. Medicare drives the narrative, and that typically when they come up with a reporting measure, a private insurance carrier, if that measure is around for a while, will latch onto that and say, well, us too, we would like some information, or if that information is publicly released, they will actually look to the public disclosure of that information in order to use that for their own purposes.
And the amount of reporting that you're having to do on quality to the government, say relative to 10, 20 years ago, is it increasing about the same? Or if it is increasing, is it increasing a lot? Like, what's the magnitude of this?
Sure. Well, it's increasing a lot. If you take a look 20 years ago, the onus was really on the government to collect what they could from what was given. And the tables have completely turned on that in a way that really the onus is now on the physician. So when you see, let's say me, for example, I'm a hand surgeon, and you come to see me for a broken finger or carpal tunnel syndrome. What you would find, if I wish to be a reporting physician who's in compliance with many of the guidelines of participation so that I don't get financially penalized for being a non-participator, I might now ask you, or have my staff ask you, whether you're a smoker and whether you've tried to stop, whether you have problems with weight gain and what we can do with your diet to change that, or all of the medications that you're on for the various things, the other health issues that I don't treat. So it very much brings forward the fact that I end up addressing, as a specialist in a narrow field, many things which are outside my realm. So not only is there greater reporting, but the broadness of the reporting ends up snaring a whole bunch of fields that really distracts then from what I do, which is a very narrow field.
Sure. Okay. So I'm a person who likes to believe human nature is a positive thing and government's trying to do good for us and all of that. So what were and this is reporting quality metrics, that seems good. What are the intentions of the government in doing this, and the people that are deciding on these quality metrics, do you think they're competent to be doing this? Are these good metrics that are being developed by people that know?
Sure. I really believe, as I stated in the book chapter I wrote, Purple Solutions, that these are smart people who are well-intentioned. I really do believe that the intent of improving quality and then reducing cost, it has been the mantra of every administration that has come and gone, every Congress that has written laws in this area. And I do believe that the people who are writing these rules are intelligent. They are, in some cases, physicians, or they are guided by physicians. The problem that we run into is, although they sound good, in healthcare, there are many things that sound good and then biologically don't end up being good. They end up being the inverse of what you expect. The human body is very complicated that way. So the issue we get into is, if you do something that sounds good and there is not a large body of underlying data and rigor and scientific study, what you end up basically doing is constructing an experiment. You have an idea and you put it upon the entire public through regulations, and then we watch how that experiment goes. Because so many of these were born of ideology rather than underlying science. And I think that's probably one of the biggest drawbacks, is that at a political level, there are many things that are ideological that when you really get down to the science, as this pandemic has shown us, the intersection of what ends up being true in medicine and health and what we wish to be true, they are not always the same. So when you apply them on a large scale, you actually make big moves in healthcare. You know, physicians and hospitals do react to their payments being cut and their access to patients being removed. So I do believe that these policies are born of good intent. They really are. But I think the whole idea that you could legislate quality of care, I think it's just a failed premise at its root, in that healthcare data changes so rapidly. Like the pandemic showed, we were doing this, and then a study showed that that was a bad idea, and we pivoted. And to a public observing this rapid change in healthcare information, I think it's probably frustrating or a bit unnerving. But the truth is, that is the way medicine is. A new study comes out that refutes prior information, or an old study is revisited and the data is found to be flawed, and we modify what we do. And the thing is, healthcare moves fast enough and information comes fast enough that it takes so long to pass legislation, and then it sits on the books for years and years. And we continue to have to follow those guidelines in a way that, instead of these regulations really promoting best practice, they really tend to endorse old and, in many cases, harmful practices that have subsequently been disproven.
Yeah. No, and I think your example of COVID was a good one. We've seen a lot of pivots, and some of it is the media too. But, you know, should we take hydroxychloroquine or not? And I know there was a big clinical study done recently that completed not long ago that had a good solid conclusion on that. And then should we be wearing the surgical mask or not? I remember in the beginning we were told not to, and then we were told to. So
I would endorse those. Yeah, I believe the data's there on those.
Yeah, and I still see studies coming out, and so that's sort of a point well taken. Is the science and the medical best practices is constantly evolving and sometimes very fast. So I
Sure.
guess you kind of maybe answered my next question largely, which is what's the downside of these federally mandated quality reporting requirements? Because like I said earlier, it seems like a really good thing to require certain quality metrics so that you avoid, chaos and charlatans in healthcare and make sure that consumers are taken care of. I mean,
Sure.
I guess your point was that you need to be able to adjust to the science and best practices, and one size doesn't fit all. I mean, is that it, or is there more to it than that?
I can think of two other things that these regulations harm us through. Number one
Yeah.
is the tremendous cost.
Hmm.
When we do reporting, it's no longer in the flow of information. Therefore, it takes additional staff and infrastructure to do. And the American Hospital Association did a good study I read a couple of years ago. And what they looked at is a medium-sized hospital and how many staff does a medium-sized hospital need in order to gather that data and then
Uh-huh.
collate it in the way the federal government wants and then transport it to the federal government through electronic interfaces. And what they found was that it took 59 full-time employees at an average-sized hospital to do federal reporting. That
Wow.
is an astronomical cost to our healthcare system for each hospital that
Yeah.
could have been used in direct patient care. So I
Yeah.
think the tremendous cost is one that is completely aside from whether we're providing good care or not. And
Hmm.
I would say the other thing I can think of is the return to paternalism, in that
Hmm.
when I started healthcare, a bygone era before mine was that the doctor knows best and the doctor will assess your information, he'll tell you what's right, and you'll follow that. As
Hmm.
I came into medicine and medical school, that completely changed. And we were told that the patient is the center of healthcare. And you, as a physician, as a doctor, the word doctor actually, if you look at its derivation, and physician is teacher. You are empowered to teach the patient about their problem, to paint the alternatives, to nurture them and help them along the way. But in the end, the patient is the center of your care and is the central decision maker. So there was this huge migration from paternalism towards patient empowerment and shared decision making.
Yeah.
And I think that was a real positive. And I grew up in that era in medical school, and I practiced that to this day. And I really think that that still is the right way to practice medicine.
Seems
With
to fit with
federal
American culture
regulation,
because we're very individualistic. We want to be in
sure,
control of things. I mean, it
I,
fits.
I think it is. It is the right way to be, and
Yeah.
it's enlightening to patients when you give them information that lets them decision make. They can take that information home. They can process it. They're not left with just what gets done to them. They
Yeah.
have the why. They can think about. They can revisit. But with federal regulations, insidiously, we have returned to paternalism. And
Mm.
it's interesting how the federal government actually sits in the exam room with us in a way that patients, I really think, would be chilled to know. In that,
Mm.
when they listen to their doctor's advice about you should do this and we should get that test and you need to come back, in X number of months or years to do this, I don't think patients understand that those words said to them in many cases are not based upon the underlying experience of that physician. They're not based upon the articles that that physician has read in their field, but they are based upon regulations that have been put in place that penalize the physician if they don't get the patient to do that and incentivize the physician financially if they
Mm.
do. And I think it is that sort of hidden element in the exam room that most patients really don't appreciate.
Mm.
And in the book chapter that I wrote for Purple Solutions, I actually give a very clear example of a family member of mine who was undergoing very critical care, and a caregiver came in to express what should be done, which was verbatim from a healthcare guideline that had already been proven as harmful to patient care. And
Mm.
there was a year and two lag between when new data showed something different and this idea had not yet been removed from the hospital's processes. So I think that return to paternalism that is now part of accountable care organizations. If you haven't heard of them, these organizations are an semblance of doctors and nurses and administrators and hospitals that are all coming together and are supposed to wrap a population and account for their care. You are responsible for the good health of a certain number of people in your community. And it sounds really good, and you get rewarded if that group does well health-wise, and you get penalized financially if they don't. The problem is the idea of an organization accounting for your care instead of you being responsible for your own care. That is a complete paradigm shift.
Yeah.
I believe that nobody is more interested in your own care as you are. And this push towards organizations being responsible for you rather than you being responsible for you, I think is a premise that just isn't going to play out in a way that gives us better quality at reduced cost.
Yeah. And I think if patients and consumers understood that, they wouldn't want it that way. I mean, it's paternalistic. It's kind of Orwellian too. There's this behind the scenes force dictating what should be done. So, and to your first point about, it being expensive to have all this compliance in place, I think maybe you talked about it a little bit. We had the former president of the AMA wrote a chapter as well about her concerns about small physician groups being able to compete with the large provider networks. And part of the driving force for that were the regulations that were so expensive to satisfy that small provider groups couldn't do it. So they had to kind of be taken in by the larger, what she called the industrial medical complex. So those regulations also led to that.
Dan, that I said fortunate in that I started my life as a computer science major, and I actually write healthcare interfaces for the federal government for hospitals to submit data. So I understand the regulations. I know them down to the lines of code that help transfer that information. But maybe one thing you don't know is I am a non-compliant, non-participating physician in the federal quality programs. I analyze in a very data-centric way how much effort and cost my staff would have to expend to comply, all of the additional distracting sort of health elements I would have to get from my patients that completely were unrelated and distracting from the treatment of their hand. And when I did the cost analysis of it, it actually was a losing proposition. So every single Medicare patient I treat, every day I treat patients in my office, I receive a fine. On every single statement I get back from Medicare, it tells me I would have received this, but because I don't agree to report quality metrics, even though I report in mass for the hospitals, on a personal level, I have found that distraction from patient care, it rises above, and I am willing to have a lower reimbursement in order to stay focused on my patients.
So you're basically being...
There are many physicians who can't make that choice because they sit in situations where they just cannot afford to be non-compliant. And I really hope that changes.
Yeah, I hope so too. You're being punished in a way for trying to do what you think is best for your patients. Yeah. So what about, CMS under Seema Verma, which we had invited her to speak at the event and she was thinking of coming, but unfortunately it looks like she's not going to be able to speak. But under her leadership at CMS and maybe elsewhere in government, what changes do you see underway in the government that are going to improve this situation or maybe make it worse? I don't know. Are there going to be changes in how we regulate or over-regulate the delivery of healthcare at the front lines?
So Seema Verma, I've never met her, but I'll tell you, I've read her writings from before she came to her current role as the head of Centers for Medicare Services and also while she's there. And I'll tell you, from somebody who believes that regulation is burdensome and that administrative burden is costly without benefit, I could not be more of a kindred spirit to her. It was very surprising for me to have somebody take on a large administrative role who believes that a large administrative role is a problem. And she has articulated that clearly. She has said that we have failed in the past, that these regulations, when you do the cost analysis, have not worked, and that we need to unburden healthcare. So I almost feel like she should be given an honorary medical degree. She really does espouse views with regard to patient empowerment, the reduction of regulation, the return to patient-centered care that I have talked about. So no, I think CMS has already moved mountains in what they have changed. There's no doubt. And a good example of that actually happened just in the last couple of months, because me as a physician, as a surgeon especially, I like to hands-on my patients, touch patients, move their joints, examine them. That's important to me. But with the coming of the pandemic, I had a vulnerable older patient population, partly, that really did not want to come in and see me. But yet, the regulations to perform telemedicine, all that I need to do in order to properly treat a Medicare recipient and have that be a valid telemedicine event were onerous. And I had looked at them, and with my background, I certainly could have achieved it, but at great cost. Seema Verma, in striking speed, within a week or two of the pandemic reaching a high level, she immediately changed how Medicare views telemedicine. She rewrote the rules, she suspended the onerous ones, she put in place new ones, all within a week's period of time. And telemedicine has advanced in the last 2 months more than it has in the decade that preceded. So I have really been impressed with how Seema Verma has been able to take issues that are wrong in healthcare, and she is surrounded by a smart group of people who also help point out, well, if we want to make this better, what would the healthcare community respond to? And I have been truly impressed with the moves she has made in CMS.
These changes, I've talked to other people too about, how COVID has induced a rapid change in policy and regulations in response, some of which have led to, an improvement in telemedicine and removal of barriers. In that sense, COVID is obviously a horrible thing, but it forced the system to adjust and make a change that's probably good. Is that going to be permanent, do you think? Is that these changes in regulations?
It's as permanent as the regulatory changes are.
I suppose.
No new technology became available during COVID.
Yeah.
The technology that we all embrace has been there for years and many years. It has been used by industry, other sectors, and has not been used by the healthcare sector except to a very small amount because of the regulations that the federal government put on top of the use of technology. So it is very interesting how no new technology grew up out of COVID. We just suddenly got the attention of our federal government to change the burdensome regulations. And it is astounding how fast it changed. In my practice, I've done now hundreds and hundreds of telehealth visits just since the pandemic began. And at the beginning of every telehealth visit, I flatter my older patients with how well they were able to get into the connection and how well that they're able to navigate this. And I ask each of them, so how many telehealth visits have you had? And I've only had 2 out of those hundreds who had ever had a prior telehealth visit with a provider. So just in a matter of a couple of months, we have taken a technology that was there and available to other sectors and brought into healthcare. And it will stay provided that the administration allows the regulatory changes that occurred a couple months ago to become permanent. And there is a big groundswell already to make those changes permanent. And if they stay permanent, I think we all benefit. But what it really was a reduction in regulation.
Yeah. I mean, some of that was medical licensure, right? So that you could talk to a doctor who's not in your state as well. So,
it really wasn't that as much as it was my ability to use different platforms of technology, because there are always data privacy issues. And the federal government painted very high the bar that you had to cross in order for it to be considered licensable and valid. And then there were a whole host of little check boxes that you had to hit with regard to what you were doing during your telehealth visit and why it was telehealth versus in person. And then there was a whole other basket of, well, how do you actually submit a claim for payment to Medicare? And the process was completely different for telehealth than it was for a standard, in-office visit. So the system was needlessly complex. And what Seema Verma did, with the strike of a pen is she said, doctor's visits in person are the same as telehealth. If you are engaging with live video and communicating healthcare information in an interactive way, we consider that to be valid engagement. And just by that one small change, the floodgates opened for our ability to do telehealth. And it was a very positive, my seniors who I treat, they were so thankful, and they have really no idea that there was a single person in Ms. Verma who truly just changed the landscape and their health in the process.
Yeah. I mean, it's going to make healthcare more accessible too. Some people have trouble with transportation, or if you're living in a rural community without much healthcare, it's going to be good on a lot of levels, I think. So.
Oh, I will be a permanent, I will permanently be doing telehealth unless the regulations walk back my ability. No, it is here to stay for me, provided the government feels it similarly.
And that kind of gets to my next question, but maybe you already answered that one, is if you were in charge in the government, what changes would you make to improve healthcare delivery or keep us moving in a good direction? It sounds like you're kind of pretty happy with some of the changes that are happening this year. So.
Sure. I think the other thing, if I had to think about not only reducing regulations, I think when we look back retrospectively at regulations and whether they've achieved their endpoint, it really is a storied tale of failure. And I detail that in the book chapter, analyzing several of the largest, most expensive programs that the federal government has initiated to prove quality. And when good scientists with a lot of data look back years after those programs were initiated and sometimes terminated and figure out the benefit, they find them failed. So if I had to pick, what would be my number one, it would be that we truly do not keep traveling this path. It seems like every new administration, every new Congress that gets seated has these ideas, and their term is short enough that, unlike myself, who's now 20 years in and has watched them come and go with poor result, I believe just educating our legislature that this is a failed attempt because the underlying premise is failed. If you believe that you can craft legislation for patient care that is more sophisticated than a physician who grew up their entire life focused towards patient care, I think that's a false premise that you have to try to extinguish. Because I do what I do because of the pride in what I do and the enthusiasm for reading my journals every month, communicating with other physicians about complicated cases. That type of passion for best patient care, you can't write that into legislation. Legislation is only going to stymie that. So I think to reduce the burden, and I think the other thing I would do is cost. I think consumers need to return to the market of healthcare, because if you don't know what your care costs, there's no way that you can actually, as a patient, help the system repair it. And the analogy I think I gave earlier with regard to when you have an urgent health condition, do you go always to the emergency room, or do you see your primary doctor, or do you go to a small urgent care clinic, or do you check on your app to see a specialist who you can have immediately available 24/7? Well, those different venues of care have very different costs and different pros and cons. And until you actually put cost into the equation, people aren't sensitive to that. So I think consumers of healthcare, just like consumers of any other service or product, they really need to know, or they are not going to be good participants in helping us control costs nationwide.
Right. So price transparency, and there are changes underway to require that now. Yeah.
Sure.
So, well, that kind of leads into, I guess, my very last question is, we have an election year coming up, and I guess I'm wondering, what would you tell politicians? You sort of, summarized it, I guess, previously, with regard to sort of empower at the physician-patient interface, so not so much centralized control with regulations and price transparency. But say you had Donald or Joe in the elevator for a minute or so, what would you tell them? Some variation of what you just shared with me. So
I think the thing I would try to do is to point out, which was something you asked me in the chapter I wrote for Purple Solutions, point out the history of what we've tried and what has failed, and try to educate both legislators as well as voters that this whole holy grail of legislating quality is in many ways a failed premise. It shouldn't be in the domain of a political body. It is not the right milieu in which it can flourish. So I think educating people about the failed past and trying not to have it reincarnated every 4 years, I think is an important message for me. I guess the thing is, in the end, whether in a government payer system where the government's the intermediary, or if it's private care through your employer, at the end of the day, somebody pays for healthcare. And in the end, it's us, whether it's through taxes or whether it's through a deduction from our paycheck, somebody has to pay for that care. And if you feel that you can get care and not know the cost of care, and if you feel that others are going to pay for your care, I think that's a failed premise. In the end, we all directly pay for our care. So I think being a part of the solution, going back towards the patient-centric approach, is what is really going to make the difference. And I see that happening. I hope it continues. And that would kind of be my message out there.
Okay, well, that's a great message. And I think you conveyed a little bit of that in your chapter in the book as well. So thanks for talking to me now, and thanks for the contribution to the chapter. And we will continue this topic on July 31st. I think you're going to be in Iceland, but if not, hopefully you could speak at the event. But we will talk on this topic in any case. So thanks very much, Greg.